On the island, we do it island style. From the mountain to the ocean, from the windward to the leeward side. On the island, we do it island style. From the mountain to the ocean, from the windward to the leeward side.
Aloha and good evening, friends of Big Island. You're watching Rise Above Big Island, which is a 30-minute talk story on health. I'm Dr. Kimo Alameda. I work for the Department of Health. I'm also a psychologist, I'm a trainer, and I'm a consultant, and I'm a proud father of 7 children, all under the age of 14. Which means I wear many hats, which means I view health from many different perspectives. And so today we're talking about health, and we're talking about more specifically the healthcare home models that are right now prevalent in the United States. As you know, health reform, Obamacare, whatever you want to call it, is very popular, and there's a lot of folks such as myself that are concerned about health and the well-being of our own people, especially here in Hawaii. So today we have a special guest. I'd like to introduce to you Paul Strauss, who's the Chief Executive Officer of our Bay Clinic right here in Hilo. Paul, would you like to share a little bit more about yourself for the viewers?
Oh, certainly. Been raised in Hawaii and grew up on the east side of Oahu, went to Kalani High School, and I've got a family of 2 with grandchildren as well, 5 grandchildren, so
wow.
I too have my tasks. But I've been on Hawaii Island for about 4 years now, associated with Bay Clinic, and have really felt that we're contributing immensely to the community and serving a very much needed health demand.
Awesome, awesome. You know, let me share with you, Paul. I haven't been real familiar with the different healthcare models out there. You know, I have a primary care physician, and so, you know, when I have an illness, I go to the doctor. But I don't know much about Bay Clinic. Tell us a little bit about what makes Bay Clinic different from, say, just going to a physician.
Okay, let's talk a little bit about Bay Clinic as an entity is what we call a federally qualified health center. And on Hawaii Island, we actually have 3 organizations, Bay Clinic Family Health Centers, Hamakua Health Center, and West Hawaii Community Health Center, who are federally qualified and oftentimes referred to as community health centers. Those centers provide, both by design and desire, a wide array of services to patients that are broader and deeper than you might find in a private physician office.
Wow.
And I can give you some examples of that. So the spectrum of services involves medical primary care, dental care, women's health, pediatric health. It involves behavioral health. We also have many social support workers who assist patients and families with other social needs they have that impact their health.
Wow.
Such things as eligibility assistance to get funding for medical care, financial assistance, housing, a whole myriad of needs, transportation, all of those elements that lend itself to good health.
That's amazing. You know, I was recently introduced to this concept called the social determinants of health. And Paul, I don't know what you think about it, but it fascinates me because what it suggests is that our health is based more than just the individual choices that we make. You know, it's housing, it's whether or not we can manage our stress, it's whether or not we can get to the doctor's appointment. And so when you have a healthcare, which is basically all in one place, do you think that that people will be more susceptible to receiving health care in that format? For example, dental care, psychosocial care. What do you think about that?
Well, let's talk about what our environment looks like in East Hawaii, and I'll speak from Bay Clinic perspective. We have many elements that contribute adversely to health status of our community. Highest poverty, highest unemployment, many disease entities that are prevalent in the folks that we treat, diabetes, hypertension, obesity, So we have many disparities that impact the health of the individual and consequently the health of the family.
Yeah.
Okay?
Right.
And that's why community health centers serve such an important role in serving primarily the underserved and people who are on public assistance programs who might not otherwise get assistance in the absence of community health centers due to physician offices being over at capacity, not being able to see people that are uninsured, and some not accepting new patients in their panels.
Wow. So does that mean, so what is some of the criteria then for becoming eligible for Bay Clinic? Sounds like a great place. I'd like to come. How do you become eligible?
Any and all individuals may come to our clinic regardless of their ability to pay. Okay? So in our mix, we have a full array of folks who have commercial insurance, like myself. I'm a patient at Bay Clinic. Medicare, Medicaid, and individuals who are totally unfunded.
Wow.
And we have provisions which we call sliding fee scale or sliding fee schedule, where we will ask for a contribution, a minimal contribution, predicated on their income level, okay? And if the person does not have the ability to pay anything, we still will not turn them away.
Wow.
So in answer to your question, anyone and everyone is eligible for services through any of our 6 locations throughout East and South Hawaii.
Let me ask you this. Do you think that this, you know, I went to a conference not too long ago, and the conference was on the person-centered healthcare home model and how this might be a new model of healthcare for communities such as ours on the Big Island. I think it sounds like a great idea, you know, where you have your primary, so you come to primary care, you might, you know, have feelings of sadness or symptoms of depression, and then they do a warm handoff to the psychologist who's at the cubicle next door, and then as you talk and they find that you may have some dental needs, and so then you go, you know, to the office, you know, several steps away, and it's like healthcare is all in one place. That sounds almost like healthcare heaven. Why not everybody? How is it that we can get more folks on board, do you think?
Well, the patient-centered healthcare home, as you've referred to, is an evolving model of delivery, and many community health centers, as well as other provider groups, are beginning to form this type of coordinated and integrated healthcare model. We need to be, in terms of how we qualify that, though, is many of the services can be co-located, but the key is coordination of care.
Gotcha.
And coordination of care may be with specialists who are outside that environment, hospitals, ancillary service providers, i.e. labs, you know, diagnostic labs. But the core element of it is having a patient-centered healthcare home with an assigned personal care provider, typically a physician, okay, who is supported by a team, okay? And in that team, it's characteristically, it's an interdisciplinary team. It involves nurse practitioners, physician assistants, physicians, nurses, RNs, medical assistants, what we term patient service representatives, who are individuals who support patient needs in a myriad of ways, much like we talked about earlier in terms of insurances and looking to link them with their needs outside for housing and clothing and financial assistance, along with the array of providers and provider types that we talked about, dental, behavioral health. We have dietitians. We've recently, in the last 2 years, also introduced the PharmD, Doctor of Pharmacy profession into our environment through an academic affiliation with our own University of Hawaii at Hilo College of Pharmacy.
That's right. That's right.
So it's a very unique model that brings yet another professional resource that can sit down and consult with patients regarding their medications, the interactions. They can do reconciliation of meds with them and educate the patients.
That sounds great. You know, in our own profession, in the psychological profession, let me ask you, Paul, well, let me tell you first that there's a lot of disparities around healthcare, behavioral healthcare. Particularly Native Hawaiians are diagnosed almost twice as much with schizophrenia than their Caucasian neighbors. Asian Americans utilize care at a much lower rate, behavioral health care, than do their ethnic neighbors. In our own system, adult mental health division, we have statistics where Asians represent over 40% of the population, but they only represent something like 15% of our consumer base. So behavioral health, well, if you look at psychology in general, it's kind of a Western phenomenon. You know, and not every culture kind of, you know, accepts that way of healing, which might explain a little bit of why the so low access numbers to our centers. But what's interesting is, in terms of what door they prefer to go into, which makes the person-centered healthcare home model really, I think, attractive to disparate groups, is that a lot of Native Hawaiians and Asians would rather go to the primary care door than going through the behavioral health care door because of the stigma of mental illness and all. So my statement in question is, you know, my statement is, if we move towards this person-centered healthcare home model, you know, it's a lot of saving face, if you will, by going to the primary care physician and, oh yeah, I have depression or I have mental illness. You know, that can be a warm handoff. Whereas right now, the system is, if you have a mental illness, you got to go to the mental health clinic. Okay? You know, the big sign outside. So I'm thinking that if we move towards this integrated healthcare home, that we might actually find the behavioral health care interventions more receptive to Native Hawaiians and Asians. That's just my thinking. What's your thinking on that, Paul?
Well, I think you brought up a very important point. And in the model that we are evolving, our behavioral health professional, which we utilize right now, licensed clinical social workers, are a part of that team. Mm-hmm. So when the patient presents to the primary care provider, mm-hmm. and let's use Paul as an example. Okay. Paul presents to his primary care provider, and I say, gee, you know, I've had it really tough, and I'm feeling a little depressed. Yeah. Or if the provider says, you know, you seem like, you know, you're a little depressed, given your family situation, they can pull in that behavioral health professional at that point. Really? Introduce them, oftentimes right in the exam room. Right on the spot. Right on the spot. It's an on-demand kind of service where there's a brief intervention in terms of a cross-introduction, and oftentimes we refer to these folks as healthcare coaches. Yeah. And so they can sort that out. And then if necessary, they can structure follow-up visits where they can sit down and really look at what they can do to address the individual's concern, set up a plan, set up goals, and follow up accordingly. And we're finding that to be very effective. Mm-hmm. It also assists the primary care provider, who oftentimes may have to spend an inordinate amount of time with an individual. And now we've got them seated with a licensed clinical social worker or a psychologist in many of our centers as well, whereby they can spend the time they need to consult accordingly.
That's great. You know, I've been doing some research prior to this interview, and it's amazing on some of the research that suggests almost up to 80% of initial visits to the primary care physician is stress related. And that primary care physicians disperse psychotropics at a much higher rate, you know, for depression or mental illness than do psychiatrists. And so I'm trying to think, well, what is the benefit for our primary care physicians who are currently have their private practice? What would be the benefit for them to come into this model, to move into this model, when they might be already doing this type of coordination? And so in my mind, I was thinking, hey, maybe the benefit is a reduction in hospital visits. Mm-hmm. Maybe the benefit is a reduction in chronic disease, because there's a high correlation with depression and chronic disease. But I don't know. What would be the benefit for primary care physicians to move into this model?
In terms of the integrated behavioral health model? Yeah. Well, I think one is they've got an expert resource available to them for their patient and the patient's family, if necessary, that can address situations on a more social psycho basis than that of the medical care that they're providing. And then that, as you said, behavior modification is what good health is all about. And behavior modification, who best can come from licensed clinical social workers, psychologists, etc. So it adds value to the patient's health and the healthcare outcomes. In our model, we also have a very evolved chronic care self-management group type model developed, where patients come together in groups, okay, to address such disease disorders as diabetic care, where behavioral health is actually involved with the group of patients, educating them on eating modification, etc. That's coupled with dietitians, it's coupled with medical providers, and the pharmacists that we spoke of earlier.
Wow.
And so all of those folks add to the ability of the patient to be educated and begin to self-manage and control their destiny in terms of their health.
Yeah, that's great. That's great. You know, I have some primary care physician doctor friends, and we talk about this model, and the thing that comes up often is, you know, so it seems like I'm going to be working harder. So how does the reimbursements work? And I read recently in the paper with Hamako Health Center, kind of experimenting with HMSA on this pay for performance. Tell us a little bit about that.
The pay-for-performance model is evolving with many of the funding agencies, Medicare, Medicaid, and private insurance agencies as well. And what they are looking at is, instead of paying for activity, i.e. I did a visit, so I get paid, they're also extending payment for improved healthcare outcomes. And there are many programs that many of us are involved in where we're actually looking at clinical outcome measures as the determinant of the value of the care that we provided, or the quality of the care we provided. So for example, in the program I just mentioned earlier, we are an accredited diabetic education site. We're accredited by American Diabetes Association, and we measure the outcomes of what we term hemoglobin A1Cs, which is a clinical determinant of diabetic status, and that then we can have evidence-based outcome measurements that tell us, are we truly doing a good job, and is the patient in fact impacting their health? And that's shared with the patient as well. Okay, so what funders are doing, they're beginning to incentivize providers for positive healthcare outcomes. And that's how the system is becoming a little bit reformed, if we might say, use that in terms of reimbursement methodology. So it's a combination of fees for the service you provided, coupled with incentive arrangements for quality outcomes.
That sounds great. I don't think many of our primary care physicians might know or be aware of that payment options. So they get basically a base rate or fee for service, but if they're finding that in their outcomes through this test, say, the diabetes, or maybe a reduction in hospital visits, or emergency care, that our insurance providers or payers will actually give them a bonus. Some sort of a bonus.
Yeah. And what is happening in our broader environment right now, there's a lot of dialogue going on between funding sources and providers throughout the system, not just community health centers, private physicians, etc., in looking at these models in their practices.
Wow.
And so that's a way of incentivizing them to create the patient-centered healthcare home. And the patient-centered healthcare home is predicated on that relationship the patient has with the primary care provider, and then how those other services are coordinated and integrated may differ by practice, because not all practices have the array of services that a community health center may have, but they have access to coordinating that with others.
That's great. That sounds great. I love the model. I love the model. There's something right now on the Big Island. I'll ask you this question, Paul. It's called the Beacon Grant, and I think tied to it is this notion of electronic health record, which is another part of this reform, if you will. So if you have a model change in healthcare, and if you have a payment change in healthcare, you certainly need some electronic or technological advances to accommodate those two entities. So tell us a little bit about the electronic health record and how you envision that being helpful to the healthcare model.
It's not only helpful, it's essential.
Really?
It's absolutely essential to support the patient-centered healthcare home. In order for us to monitor an individual's health, measure outcomes, report those outcomes, you have to have a very sophisticated tracking mechanism to do that. The electronic medical record, or EMR as we often refer to it, is evolving in many practices. In our practice, it's been instituted in 2005.
Wow.
And we are fully utilizing our electronic medical record, not only at our single sites, but we can communicate with our 6 operating sites today.
Wow.
So if I go to Hilo Bay Clinic Family Health Center today and to Ka'u Family Health Center, which is one of our health centers, tomorrow, they will be able to retrieve my records, even though I may be seeing a different provider for an urgent need that I might have in South Hawaii. That record system also provides evidence-based criteria for treatment of various disease disorders that our providers and staff utilize in the care of the patients. It also provides patient education information that can be produced and shared with the patient to take home in controlling their care, and then captures the information which we can trend and track both for the individual patient as well as collectively for all our diabetics or all our hypertensive patients. And that allows us to have a report card as to how are we doing with the 18,000 people that we care for annually. So that's an important element. The next wave is what the Beacon Grant is providing an opportunity for our community to link with one another, so that if I incur an emergency room visit tonight, tomorrow morning, my primary care provider at Bay Clinic Family Health Center would be aware that I had that event and could have coordinated follow-up. Okay? Right now, today, we have staff that run up to the hospital, that work with our patients in coordinating discharges from the hospital in the absence of electronic exchange of information. Okay? So there are efficiencies that come out of this, but more importantly, it's better quality care and information that is available to all of the providers who are involved in treating that patient from the patient-centered medical home model.
That's fantastic. That's like almost like a three-prong approach. You got this model that has been tried and tested. I know there's a lot of pilots across the country that has shown actually an increase in healthcare and a decrease in the disparities. So you got this model, you got payment reform that folks are kind of experimenting with. You got the electronic health record that is absolutely essential, like you say. And with the electronic health record, it sounds like, too, that there'll be a decrease in the duplication of services.
Absolutely.
Because you don't have to do lab tests twice.
Absolutely.
Right?
Or just think about when you and I go to see our provider, and you're filling out the intake form, and it's like, okay, what meds are you on? You know, when did you have your surgeries? Every time you're going into a new door, all of this repetitive behavior on behalf of the patient, number one, okay? And number two, providers not having the ability to exchange information. And the Beacon Grant has some very key focuses that will really build a better healthcare delivery system for us here on Hawaii Island. Yeah. In looking at the service we provide to the patients, improve healthcare outcomes, and hopefully reduction of admissions to the hospital, emergency room visits, by coordinating and integrating care on all levels, specialists, hospitals, ancillary services, and primary care providers.
Fantastic,
Yes.
fantastic. You know, as we come to a close here, I'm thinking of maybe two more areas. As I mentioned, I got the, you got the model that's changing. You got the payment reform that people are kind of excited about. You get electronic health record. Paul, I'm also thinking about the workforce. It seems to me that with this new model, we might have actually a different type of worker, maybe a cross-disciplined worker, a nurse who understands behavioral health, a behavioral health person who understands primary care. Do you think that if we move to this model, that our workforce competencies will have to change or increase? What do you think?
Wow. Tough question. Let me answer it in a couple of ways. Okay. First of all, let's talk about workforce. Okay. As you well know, our environment on Hawaii Island, we have a scarcity of adequate resources to care for our community. That's right. So recruitment and retention of qualified individuals is a compelling issue for healthcare organizations. Number two, payment reform will provide us the opportunity to utilize alternate resources to assist the patient and family in getting the provision of services they need to support their health, because we won't be restricted to a fee-for-service system that can only be paid to a provider of care, where maybe an outreach worker that knocks on my door on Saturday morning and says, Paul, did you take your statin to lower your cholesterol? Yeah, I like or that. How are you doing with that? Or, oh my gosh, you need help in this environment. Let me see what we can do to bring that help to you. I mean, we're talking some real basics here. Even transportation. As the gas prices went higher, we had patients telling us, I can't make the appointment because I can't afford the gas to go in my car to come to your site. That's awesome.
I hear you. I hear you. So what, as we close here, I really appreciate this interview with Paul, and I hope you as the viewers appreciate this as well. We have an opportunity to change healthcare, and models such as the one at Bay Clinic is I think, awesome. But there's a lot of kinks that we need to work out. There's a lot of people that we need to have kind of bought into this model, and I think we can make it happen. So again, I'd like to thank Paul for coming.
Thank you, Dr.
on my show. I really appreciate it. And for you viewers of the Big Island, remember to always rise above. Ahui ho.
On the island, we do it island style. From the mountain to the ocean, from the windward to the leeward side.